Thank you very much. I appreciate the very kind introduction. And again, it's an absolute honor to be speaking with people at the SSBMT Congress. Quite amazing collection of talks so far. And of course, thank you to Menarini Stemline for sponsoring this. So for this session, I'd like to speak about targeting nuclear export proteins in myeloma and a little bit about how this may fit into the relapse refractory world of myeloma. So again, at the current moment, we still deal with myeloma in the setting of classes of agents. And given the more recent data, and again, separate from the T cell redirection therapies like bispecifics and CAR Ts, which are essentially given as monotherapy at the current time, the standard in relapse myeloma is triplets and quadruplets of taking one drug from each of a different class. We don't yet really use two drugs within the same class, although those studies are ongoing. And we can see a variety of the classic therapeutic areas like IMiDs, proteasome inhibitors, alkylators, steroids, antibodies, and signs are a very interesting type of therapy. So I think upfront therapy is really kind of set in as mostly quad-based therapy, definitely triplets with regimens like VRD. But now that DARA VRD is becoming both utilized in transplant eligible and ineligible patients in myeloma, we recognize that patients still tend to progress on lenalidomide going into their second line, either receiving DARA VRD, autologous transplant, lenalidomide maintenance, and then progress, or they progress on daratumumab and lenalidomide. Either way, many patients enter the early relapse setting either proteasome inhibitor naive or proteasome inhibitor sensitive. As such, one of the main options for backbone of therapy in early relapse is carfilzomib. And as we can see here, there have been a number of studies looking at different combinations and dosing strategies, as well as different partners. And one of the things that carfilzomib has struggled with is how do you dose the drug? Do you infuse it over the originally approved 2 to 10 minutes or 30 minutes? Is it given once a week or twice a week? Do we give it at doses of 20 per meter squared, 56, 70 per meter squared? It's a little all over the map. For the most part, we give once weekly carfilzomib. It is a far better tolerated regimen for patients, never really going higher than 70 per meter squared. And when combining with an immunomodulatory agent such as pomalidomide or lenalidomide, never go higher than 56, as some early studies have shown that higher dose carfilzomib at 70 per meter squared with immunomodulatory agents has a much higher risk of dysrhythmia. Now, we also recognize that for many people, carfilzomib may not be an optimal strategy. We've learned from the endurance trial that in patients over the age of 70, specifically those with poorly controlled high blood pressure, the cardiotoxicity may be a little unacceptable. As such, at least in the US, pomalidomide-based regimens are the main backbone of our first relapse. And it's been studied all the way back dating to the 003 study, which led to the approval. However, there we saw a median progression-free survival of only 4 months with around a 30% response rate. Now, the two leading combinations where we use pomalidomide would either be dara-pom-dex based on the Apollo and Aquelius studies, or isatuximab pomalidomide dex based on the Icaria study. Either way, the progression-free survival improves to around 1 year. Now, even though daratumumab has become increasingly utilized in the upfront setting, we recognize in early relapse that many patients may either be DARA naive or DARA sensitive, as many patients are maintained with lenalidomide alone as maintenance after induction, either post-autograft or post-triplet or quadruplet induction without autograft. As such, daratumumab-based regimens represent a mainstay of early relapse myeloma management, and we see here a variety of doublets, triplets, and even quadruplets with these different therapies, with actually the most common regimen in the United States being daratumumab pomalidomide dex. However, we've started to recognize that the combination of a CD38 and Kyprolis, namely DKD or ISA-KD, has shown some of the highest and most durable responses in early relapse, some of them even rivaling CAR T data when we look at the both the IKEMA study and the Candor study, with IKEMA showing response rates, median progression-free survival of 30 to 40 months. But ultimately, as we move, and I mentioned earlier, we move all of these drugs to first line and first relapse. the novel therapies, we need to go beyond this when we go into subsequent lines of therapy. We need to look at additional agents. So again, we talk about the BCMA and non-BCMA bispecific antibodies, and we recognize that these drugs are highly efficacious. Although right now the current approval in the United States for the bispecific antibodies is fourth line plus. So while these are extremely efficacious, I think there's a gap of how to optimally manage patient with or without T cell redirection in between first relapse and fourth relapse. We recognize that moving up CAR T therapy to early relapse may help to overcome some of this. And there were two large studies performed, both the KarMMa 3 and CARTITUDE 4 studies. KarMMa 3 and CARTITUDE 4 both compared CAR T against standard of care and similar in concept, but in execution far different and ultimately led to different outcomes. So KarMMa 3 looked at patients with 2 to 4 prior lines of therapy and compared ide-cel with standard of care regimens. And there were a number of standard of care, including Darapom-Dex, VPD, KD, and ultimately saw an improvement in an overall response rate from 42 to 71%, an improvement in progression-free survival from around 4 to 14 months. It's important to note that the KarMMa 3 study allowed for crossover. So patients that were randomized to the standard of care arm were allowed to cross over to receive ide-cel in the relapse, and this definitely impaired some of the long-term data. This is in stark contrast to the CARTITUDE 4 study, which compared cilta-cel versus standard of care in 1 to 3, not 2 to 4 prior lines. And here the control arms were either Pom-Vel-Dex or Darapom-Dex, no crossover allowed. And we saw an overall response rate improve from around 67 to 85%, and an extremely impressive PFS curve. We like to say the PFS curves are so different, you could drive a truck through it. And again, median PFS not yet reached, but we can see it looks like it's going to be a very impressive number. But ultimately, we need to consider a variety of non-CAR T cell therapies or non-T cell redirection therapies, because CAR T is really best suited for younger and fitter patients, much in the same way autologous transplant is. And we recognize that in many countries, the average age of myeloma is at or over the age of 70, which may preclude more intensive therapy. Therefore, we need to think about additional mechanisms of action outside of T cell redirection and outside of IMiDs, PIs, and monoclonal antibodies. And that's optimally where the selective inhibitors of nuclear export fit in, namely selinexor. This is a first-in-class orally bioavailable sign. And although it's been studied in a number of places, in the US, it currently has 3 approvals as selinexor and dexamethasone in late-line therapy, selinexor, Velcade, Dex in early-line therapy based on the Boston study I'll discuss in a moment. And additionally, it has an approval in diffuse large B-cell lymphoma. But ultimately, where we've seen some of the most impressive data from this is from the Boston study. These were patients with 1 to 3 prior lines of therapy who were randomized between bortezomib dexamethasone and bortezomib selinexor dexamethasone. One of the key things this study brought to light is the fact that in myeloma, we approve a drug, and by the time we are really comfortable using it, the utilization looks nothing like that original dosing. Meaning, we look back to bortezomib, which is approved at intravenous twice weekly. Now we give subcutaneous once weekly. The Dara used to be IV, now it's sub-Q. Carfilzomib used to be twice a week, now once a week. Same thing here with selinexor. The original STORM study approved the drug at 80 milligrams twice a week. It is a very toxic way to give the drug. But now when we combine it, we recognize that once weekly dosing, when given in partnership with additional myeloma therapies, is far more efficacious and far better tolerated. And we typically give doses ranging between 60 and 100 milligrams based off of the myelotoxicity of the partner drug. Here in Boston, because bortezomib has very little in the way of myelotoxicity, the MTD was 100 milligrams of selinexor once a week. Now, it met the primary endpoint of median progression-free survival and improved from approximately 9.5 to 14 months. But to me, what is the most important thing is, how do we find the optimal patient in our clinic that will benefit from this approach? Because just like with CAR T, we know some patients do amazing and some do not. The question is, where is selinexor most efficacious? And there's a few areas that are really quite impressive. One is selinexor Veldex in one prior line of therapy, as we see here, median PFS of 21 months, and in bortezomib naive patients, almost 30 months. Remembering that across the last 15 years, the majority of induction therapy anywhere in the world, transplant eligible or ineligible, has contained bortezomib. VMP, VTD, VRD, DARA VRD, VCD, the list goes on and on. But ever since the publication of the MAIA study, giving daratumumab Lendex to transplant ineligible patients, we've seen a rise of patients entering early relapse, proteasome inhibitor and bortezomib naive, and this may be a more optimal approach for those patients. The other concept is we have no true insight on how to sequence therapies. Most of our sequencing in clinical practice is based off of chronologic date of approval. We give Revlimid before Pomalyst because it was approved earlier. We give Velcade before carfilzomib because it was approved earlier. We give Tec before Tau because it was approved earlier, not necessarily because it's the more optimal way to do it. However, there's been some phenomenal work done at Moffitt Cancer Center in the US looking at the relationships of genomic predictors of resistance and sensitivity between CD38 monoclonal antibodies and signs. And it turns out there's a yin-yang relationship such that patients who are showing genomic signatures of relapse, genomic predictors of resistance to CD38 will be sensitive to sign and vice versa. Ultimately, we then subsetted out patients treated in selinexor trials, both in the STOMP trial with selinexor Pomdex and selinexor Kyprolis-Dex, and in the Export28 trial with a NextVD regimen, and looked at patients who had immediate prior DARA or did not have immediate prior DARA. And we can see stark differences in the progression-free survival curves, noting that patients progressing directly after daratumumab seem to have an inherent sensitivity to selinexor and sign-based therapy, and this may give us some insight as to how to sequence drugs, giving selinexor directly after a daratumumab-containing regimen. Now, when we look at the waterfall plot across studies looking at XVD, XPD, and XKD of patients who had just immediate prior CD38 therapy, we can see not only is the waterfall plot extremely impressive, but the asterisks here denote patients with high-risk cytogenetic disease like 414, 1416, 17p. So this may be a very potent approach, especially for patients with functional high risk. And that just literally means shorter response time. So for example, in the MAIA study, the median progression-free survival with DRD up front was over 60 months. But if I put a patient on it and they relapse in 1 to 2 years, regardless of their cytogenetic profile, they are functionally high risk, and giving them another IMiD is probably not the right thing to do. And they're CD38 refractory, my next regimen would be XVD. So here we see the updated data that was presented at EHA by Mary V. Mateos from Salamanca, and we look at patients in one prior line within the Boston study, remembering that Boston included patients with 1 to 3 prior lines of therapy. Here we see an improvement in overall response rate from around 2/3 to over 80%, and an almost doubling of the median progression-free survival from 10.7 to 21 months. But the other thing to remember is that selinexor has a lot of similarities with the IMiDs, in that is extremely combinable because everyone's journey within the myeloma framework is unique. And it's important to know that we can combine this with essentially all of the other drugs at our disposal. And a lot of this data comes out of the STOMP protocol. The STOMP protocol was an umbrella protocol that allowed patients to be treated with a variety of different selinexor-based combinations in triplets as well as quadruplets, remembering that they all are dosing selinexor between 60 and 100 milligrams weekly, depending upon the partner agent's myelotoxicity. So let's go through some of that data. Here we see the STOMP regimen with XDD, selinexor daratumumab dex. And here the MTD was 100 milligrams weekly, waterfall plot very impressive, overall response rate around 70%. The question is, where does this regimen come in? For patients that I have that were progressing on lenalidomide, that I gave KPD, carfilzomib pomalidomide dex, as a second-line therapy. XDD is a great third-line therapy to recoup patients who are progressing on the KPD regimen. Now, what has become increasingly common in many places is recognition that CD38 combinations are better with carfilzomib than they are with pomalidomide. Hence, there's been a steep rise in utilization of DARA-KD and ISA-KD in early relapse. When you have a patient progressing on one of those therapies, one of our go-to regimens is the PD regimen, selinexor pomalidomide dex. Because POM does have more myelotoxicity, the recommended dose for selinexor is 60 milligrams once a week. And we can see here an overall response rate of around 60% at the RP2D with a clinical benefit rate of 75%. The other place where this is extremely useful, is in patients with leptomeningeal myeloma. This has become our go-to for patients with CNS involvement of their disease because selinexor, pomalidomide, and dexamethasone all cross the blood-brain barrier. So this is both an all-oral, which is very good for patients, very effective, especially in a post-CD38, post-carfilzomib-based setting, but it also penetrates the blood-brain barrier and is a great regimen for patients with CNS involvement with multiple myeloma. Now, perhaps the most utilized combination of selinexor in the US, at least, is the combination of carfilzomib selinexor dex. And this is from data recently published by Gary Schiller and Christina Gasparetto. Now, we recognize here the overall response rate of around 78%, clinical benefit rate of over 81%. The dosing here would be selinexor 80 milligrams once a week. And again, given the fact that the most common utilized regimen in second line in the US is DARA-POM dex, we follow it with XKD here. And I've found anecdotally that this regimen is very potent for patients with bulky extramedullary disease and large plasmacytomas. I find it to be a very potent combination. Now, the toxicity management of selinexor is a bit different from other therapies. Most of the therapies that we think about, at least the novel agents like bortezomib and lenalidomide, we think about delayed toxicity. You start off on 25 milligrams of lenalidomide, 4 to 6 cycles in, the bone marrow is having some fatigue, you have to drop to 15 milligrams. Bortezomib, we start out okay, and a while into it, the patient develops peripheral sensory neuropathy, we have to adjust the dose. This is in contrast to selinexor, where the toxicity is a proximal event. And if you're aggressive about prophylaxis over the first 2 or 3 cycles, the toxicity tends to dwindle with subsequent cycles, and you can back off on prophylaxis. So our approach has been the combination of 3 antiemetics, one of them being dexamethasone, and then adding 2 additional, either the combination of ondansetron, a 5-HT3 inhibitor with an NK antagonist like aprepitant, and if we're unable to get aprepitant, we give olanzapine. My personal preference is to give 2.5 to 5 milligrams of olanzapine the day before, the day of, and the day after selinexor dosing. That being said, if you have access to Akynzeo, which is the combination pill of palonastratron and nitipatant, that plus dexamethasone is a great prophylactic approach with selinexor. For us, one of the things that we have really utilized is rolapitant. Rolapitant has the fewest drug-drug interactions with selinexor and is dosed at 180 milligrams every other week. Now, our nurse practitioners recognized these patterns early on, and we decided to take a very aggressive tack at prophylaxis for these toxicities in the original STORM study. And we actually subset it out later on, all the patients treated in STORM with those treated at our site. The overall response rate for the STORM population was 26%. It was over 53% at Mount Sinai, and this translated into improved progression-free survival as well as overall survival. For us, there are a couple of tips, mostly the antiemetic prophylaxis early on. I usually give Zofran, rolapitant, and dexamethasone for the first 3 cycles. Once that's tolerated and we get through that, starting with either cycle 3 or cycle 4, I remove the rolapitant and or the Zofran, and then we can taper down per patient. It's known that the XPO1 inhibitors do have a predilection for the TPO pathways. When we used to give selinexor twice weekly, we were not able to overcome thrombocytopenia with TPO agonists like ramiplostim or trombopag. However, with once weekly dosing, early line relapse, it's not much of an issue at all. Rarely have to use TPO mimetics. However, if you use if you use selinexor in late line therapy where there's already marrow fatigue and TPO mimetics aren't needed, the recommendation is quick up titration. So although the package insert for ramiplostim is to start at 1 mic per kg, and then each week going up 1 to 2 to 3 to 4, we recommend rapid titration up to 5 or 10 mics per kg because that's needed to overcome the TPO blockade. So in general, aggressive prophylaxis is very necessary. Apart from that, standard approaches with supportive care, good diet, good rest. And for us, one of the big issues is that we use a lot of aprepitant, fosaprepitant, nutipitant in our patients. And because of this, over 96% of our patients received aprepitant as opposed to under 19% with the rest of the cohort. And that's one of the main reasons why our patients did better is that without this aggressive prophylaxis, patients did not want to proceed on treatment. However, as long as we provided able to maintain very well and tolerate the drug very well and able to stay on much longer. And as we've seen from the original trials with bortezomib and lenalidomide, the longer you stay on, you tend to deepen your response, which is one of the reasons why we had deeper and therefore more durable responses. The other thing to remember is that in myeloma, there are two types of drugs. There are drugs that we dose adjust with toxicity and drugs that we don't. Lenalidomide is a drug that we absolutely dose adjust with toxicity. We have patients on 15, they become cytopenic. We're unable to maintain their counts, we drop them to 15. This is in opposition to carfilzomib, where we dose a patient at 56 per meter squared. If they get a little short of breath, we stop the drug. And I would say treat selinexor like lenalidomide, not like carfilzomib. So if you start at 100 milligrams and you have toxicity, hold, drop to 80. If you're at 80, hold, drop to 60. And when we looked at patients who underwent dose adjustment, we saw that if you did versus did not have dose adjustment, we saw an improvement in overall response rate from 66 to over 81%, which translated into improvement in progression-free survival in the Boston study of just over 9 to over 16 and a half months. Now, ultimately, we still need to put this in the context of the very exciting new T-cell redirection therapies, both bispecific antibodies and CAR Ts, because they are becoming part and parcel of how we manage relapse myeloma. The question is, if depending upon the pattern of relapse, depending upon the approval in any given country, you may have to consider what to do either before your BCMA therapy or after. As far as after, we have data dating all the way back to the original STORM study, which had several patients who had progressed on BCMA targeted CAR T who went on to receive selinexor, and all of which responded. And across a number of subsequent studies, we looked at patients who have progressed after BCMA CAR T, bispecific antibody, or antibody drug conjugate. And one of the benefits is that because selinexor does not utilize T cells in order to fight, even in patients who are T cell lymphopenic, they can still respond very well to selinexor and may be a great sandwich therapy in between T cell redirection therapies to allow the T cells to recover to get maximum outcome of your bispecifics. Now, what about prior to? And one of the things we've begun to understand and talk a lot about is T cell fitness, meaning as we are leading up to T cell redirection, we want to avoid certain drugs because we know that they negatively impact T cell function. Mostly we avoid high-dose alkylators like cyclophosphamide, bendamustine, and melphalan. But the question is, what is the impact on selinexor as a therapy leading up to T-cell redirection? And one of the things is not only do we see that the T-cell activity was not impaired, they continue to have excellent interferon gamma and granzyme B response, but actually there was some evidence of improvement in T-cell function compared with the control. Now, this has led to an IIT, which was started looking to use selinexor as a priming effect prior to T-cell redirection therapy like CAR T. However, this is a little bit too soon for prime time. We're unclear if this data that's seen ex vivo will translate into real-world improvement in CAR T-cell therapy. So in summary, SVD represents a highly effective option in the relapse refractory world of myeloma. For patients who had prior Velcade-based therapy, the question is, can we use it again? Either patients who got VRD or Dara-VRD induction, transplant and maintenance, or Dara-Len maintenance, or for patients who receive DV in the relapse based on the Castor study. We know in Castor, they stopped the bortezomib after 6 or 7 cycles and continued on single-agent Dara alone, meaning that the majority of people in these settings are still sensitive to bortezomib. We go back more than a decade, and the Retrieve trial looked at patients who were treated upfront with bortezomib and stopped, not because of progression or toxicity, but patients who were transplant. And it showed that the deeper remission you achieved up front correlated to the durability of remission when you reused bortezomib in a later line of therapy. The other thing is that now, with increasing rise of DRD as an induction strategy, we have patients who are progressing now in the second line who are proteasome inhibitor naive, but lenalidomide and CD38 refractory. It's a great way to give XVD to provide two new mechanisms of action, specifically in patients with functional high risk. So if you give DRD to a patient up front and they underperform 2 or 3 years, you don't want to just go from Rev to POM. If they didn't do well with Rev, they're not going to do well with POM. Already refractory to daratumumab, XVD has shown great data from the subset analysis of Boston, and that's one of our go-tos for that patient subset. And with that, I thank you very much for inviting me to speak again at this wonderful Congress, and I'm happy to take any questions.